Hey everybody, welcome back to Dental Unfiltered. I'm Matt Brown. I'm here with my normal co-host Andrew Vallow, and today we have Chris Bowman with us. Chris is a dentist out of the Charlotte region. He runs Dental Insiders. He's a subject matter expert in case presentation and how to get a yes. Chris is joining us today. This is a subject I'm really passionate about. I think that the one place, unfortunately, you guys aren't offered the proper training in such a critical area is case presentation, chairside manner, and how to go about that. It's never taught in school. You're like kind of left out in the world to figure it out on your own. And it's really ironic we're having this conversation today. I had a long-term 4-year client of mine that I have offered case presentation to so many times over 4 years. And his answer has always been, I have an awesome case presenter. She does a great job. What do I need more training for? And I'm like, well, what happens if something happens to her and you have to replicate her? Well, she just got pregnant. She's leaving on pregnancy leave and they're panicking right now. And if they were so dependent on her as an individual and there was no standardization of that process in the practice, it was like this dark art that she protected and no one else did. And that was her territory. And now she's going out for being pregnant and they're stuck and they're trying to figure out if they can repurpose an assistant or repurpose this person. And they're scrambling right now to try to get it done by September, right? I know it's something that I trained Dr. Vallow's staff in Tampa. We did like a training seminar for all his staff and they have a standardized process and systems. It's something that really needs like solid investment, and it seems like it just doesn't happen. So why do Dr. Bowman, just to start off, why do you think it seems like it's not something that's forward in the dentist's mind to develop this across their staff and themselves?
Yeah, that's a great question. And thanks for having me on. My thoughts are that it's something that's just not focused on in dental school. It's not focused on in most of the training and CE that dentists seek. We all look for clinical training. We all receive clinical training in dental school. And after dental school, we look for more clinical training. And, in any kind of a business, you really need 3 legs to support a business. One leg is of course, the clinical skill leg in dentistry. Another leg would be the marketing leg, building the business leg. And then another leg would be the communications. You could probably also add business systems to that, maybe even make a 4th leg. Well, the problem is for most dentists, since we have a clinical mind, when we feel like our practice is out of balance, we often go get more
100%
training. And so then we end up learning more stuff that we can't get patients to do. And it gets really frustrating. I remember going back to way back to late 90s. I got out of dental school in 94. And one of my first major clinical courses was the Dawson, occlusion course. And it was fascinating. And I got back into my practice and I started discovering all these things that I could help my patients with. And I was really excited about that. But then something happened. They didn't say yes. And they listened to me and I had all these great ideas on ways to help my patients, but I didn't really know yet how to engage my patients in a way that caused them to really recognize their problems and conditions in a way that would motivate them to want to do something about it. So that's kind of what started me on my quest to solve that problem. I realized that once I could understand how to gain acceptance of my treatment recommendations for patients, as long as it's in their best interest, then it would really help them as well as help my practice. So that's kind of where it all came from. But yeah, going back to your question, most dentists don't think about this. Another thing is that in dental school, nobody says no. Yeah. No one says no in dental school. And then we get into private practice and all of a sudden patients are saying things like, let me think about it. And let me talk to my spouse. And they're just all deflections. So, once doctors begin to realize the importance of this topic, it should become one of the most high priority.
It's funny to me how resistant they are to role playing this. So me and you, this is honestly, I was very excited about this episode. Me and you pretty much do the same thing. I just do it for my marketing company and like, let's go role play this. And everyone's like, I don't really want to do that. So I just taught you the course and you want me to just let you go and hope you're good at it. You don't want to go practice. and there's just no motivation to get in there and do it. And do you think it's just because it's just the mindset that people go into that become dental professionals, or is it just resistance? And where do you think that resistance comes from?
Well, I would say it probably comes from fear and uncertainty. If there's never really been any formal training on how to communicate properly, then there's going to be discomfort with the idea of practicing that initially in the beginning, because most people aren't going to be very good at this when they start. There are some who are natural communicators. I mean, we've all seen that. There are some that can just naturally engage and gain acceptance, and natural salespeople, so to speak. And when I say sales, by the way, what I mean by that is consultative sales, trusted advisor sales. We're talking about when it's in the patient's best interest. I'm not talking about the kind of sales where we're trying to convince someone to do something that they don't really need to do or shouldn't do. Um,
Well, I think there's a negative connotation on the word sales in dental. I think it should be reversed. It should really embrace because dental is a consultative sale. It's a sale for the benefit of the patient. I mean, and honestly, there's a misnomer out there. I feel like I haven't encountered these docs yet, but everyone thinks there's these docs that are salesy that just find treatment that doesn't exist. I have a lot of dentists, like 170 or so, and I haven't really found one of these guys yet. I found guys that are more salesy and better at communication, and guys that aren't. But I feel like the guys that aren't look at those guys and go, "Oh, well, they're salesy. It shouldn't be that way," and they just label with a negative connotation. But I really don't think those. I think it is sales. It's a consultative, beneficial sale to get ahead of the dental problem and help the person. It
Yeah,
really
it
is.
just takes a rethinking of the sales process. I mean, we've all had sales done to us, and I think that's what makes people
Yeah.
uncomfortable with that process. But we've also, in many ways, had sales done for us, and I believe that when we approach it that way, again, just like you said, we can reframe the definition in our own minds in a positive way. Another thing that I like to discuss with practices and team members and doctors, because I involve the entire team when I do my training, is I want everyone to think about communication in their practices as if it's a marketing system. And every dentist wants to grow their practice. Every dentist wants more new patients. Every dentist wants their patients to say yes ultimately. But they don't usually think about communication as a marketing system. And if you go back and think about the definition of marketing, which to me means anything that you do in a business that influences someone to do, yeah, more
Generate
or less
revenue.
business with you.
Yeah. Anything that generates
Anything.
revenue is
Yeah,
marketing.
and
Anything that
it may
generates
it
revenue.
may
Yeah,
influence
yeah.
someone to do less business with you. That's bad marketing. So it's either good marketing or bad marketing. And obviously, the communication that we have in our practice will influence patients to do more or less business with you. So therefore, communication is marketing. So if we can optimize and systematize our communication in our practice, now I don't mean robotic scripts, but if we can, in a very personal, relating way, if we can standardize and systematize our communication systems in the practice, we can literally turn that into a marketing system that builds the practice and develops closer relationships with each patient. And that's what this is all about.
One thing real quick, Andrew. It's funny you say that. I'm teaching to the American Academy of Clear Aligners here soon, and there's a middle of our slide deck, and they're pretty strong, pretty strong organization, like 5,000 dentists. And in the middle of our slide deck, there's a graphic, and on one side is marketing. It says like text campaigns, email remarketing, social media marketing, internal marketing. It has everything. Then we have a bridge graphic, and the bridge graphic says case presentation, and on the other side of the bridge is production, treatment, and collections. And it's the delivery object. It's the most critical part. It's so overlooked. I'm sorry, Andrew, interrupt you, but
No,
it's so
that's
critical.
okay. I think this is some really cool stuff we're starting to unpack here, and something I always like to say, and us listeners have probably heard me say this before. The nice thing for us is that we're not selling alcohol and cigarettes. We are selling
Changing
better
lives.
healthcare for people. We're selling better lives. But we're still selling something because most of the dentistry we do isn't urgent. Most of it is not life threatening, things that need to be taken care of right now. So we still have to show that value of the treatment. And unfortunately, a lot of dentists are uncomfortable doing that. Unfortunately, a lot of dentists are uncomfortable even telling patients about everything going on. If you stop and think about your last comprehensive exam, you have a new patient, you see a lot going on. You don't want to give them a bunch of bad news. You don't want to overwhelm them. You start talking about watching things, or you don't even mention it. Maybe you make a little note in their chart, like I'm going to keep an eye on this type of a thing, because you don't want to come off as salesy. You don't want to, make that patient run away. But at the same time, guys, it's our responsibility to make patients aware of what's going on in their mouth. And so this is a conversation that I have with my associate dentists whenever we do our onboarding process. Is, guys, like, we don't watch things in our practice. We make patients aware of what issues are going on. We educate them on those issues. We educate them on the consequences of not taking care of those problems. And we also educate them on the benefits of moving forward with treatment. So at the end of the day, it's up to the patient to decide, do they want to move forward with that treatment or not? But it's our responsibility to diagnose and explain what's going on, and to give them options, and to try to encourage them to make the best decision for their health. So,
yeah, 100%. And, there's one major thing that I see that's missing from the new patient visit, the comprehensive exam process in most practices. And it goes back to a very famous quote by Zig Ziglar. I'm sure you've heard of Zig Ziglar.
Yeah.
You'll get everything you want in life if you help people get what they want. And there've been a lot of permutations of that quote, but it's something like that. And that's the thing that I believe is missing from most dental practices and most new patient visits. There's never a discussion with the patient initially before anything ever gets started. There's never a discussion with the patient about what their expectations are, what they want, what they're concerned about, what they're interested in. And even worse, going back to dental school, it's kind of like monkey see, monkey do. We learned from the instructors and from the upperclassmen, and we just started saying what they said. And a lot of their sentences would begin with something like, you need this, you need a crown, you need scaling, you need this. Well, how in the world do we know what they need if we've never asked them what they want? We've never asked them what's important to them and why it's important to them.
That's so true.
That's what's missing. And I think that's where the uncertainty comes from with dentists and team members. And then you couple that with a fear of rejection. And then you're going to see dentists and team members really backing off from their findings and backing off from the recommendations because they're afraid they're going to scare away the patient. Well, you're going to be much less likely to scare away a patient if you spend some time on the front end. And by the way, this comes from a team member, better from a hygienist or an assistant, to just sit down and discuss with a patient what your expectations and concerns and interests are. I call that the new patient connection interview, because it does establish that connection with the patients in the practice.
We have, in our training, we have a key discovery phrase we use early. What are your goals for your dental needs to bring the human train forward before you ever get into clinical? I had a doc in Florida. I was in his practice, and they hit a full mouth restoration, ended up in his chair. And he walked in and instantly started talking right off the x-ray and never asked the patient what they wanted. This is a $40,000 surgery. And I watched the patient go through the process, ended up at the front desk. I said, hey, Mr. Patient, did you find out what you wanted to find out today? He was like, no, I didn't. I was like, you mind going back to the operatory with me? He's like, sure. And I'm not a dentist. I went back. I said, what are your goals for your dental needs? He's like, I want to smile normally again. I want to be done with my dental problem. I just want to get it fixed. And they were trying to sell him like multiple arches and like there's a lot of like different piece together work. He's like, I just want 2 full zirconia arches. Now I have this much money saved and I want to get it done. And I looked at Doc. I was like, can we do that? He was like, sure. He's like, why would you volunteer all the information to you? I was like, because I asked him. You never did. That's so awesome.
Yeah, exactly. And, just recently I had a patient come in, a new patient named Allie, and she was interested in enhancing her smile. She had been to 2 or 3, I think 2 other dentists, and they had recommended different things for her. And my hygienist, Emily, introduced me to her. She gave me a bit of an information handoff about the things she spoke about with her, which is critically important. Yeah. And when I sat with her, I just looked at Allie and I said, what's most important to you about your smile? And what things are you looking to be different? And she looked at me and she said, no one's ever asked me that question before. With all the dentists she had been to, she's in her 40s, very attractive lady. And I was just blown away. But I know it's true that in most cases, patients are never asked what they want, what's important to them.
Never.
And when team members and doctors learn to do that, it changes everything. And then from that point forward, all the findings and all the recommendations can be directed toward those goals. And it changes the entire conversation. Now, when we find problems and conditions, we can say something like, this isn't going in the direction that you said you want your health to go. Instead of me saying something like, you need a crown. It's a completely different conversation. And again, when it starts with the team members, obviously it's a lot less intimidating. And then as the doctor, when I come in as the second person and I can confirm the findings of my team members, then I become the second opinion in my own practice, which again becomes very valuable because then I can confirm and validate what my team member found.
Yeah, and co-diagnosis is so important, and I want to get into a little bit more about co-diagnosis here in a second. Before we do, I want to touch on what you were talking about finding out what's important to the patient, and I think a lot of it starts with why is the patient there in the first place? What type of visit are they there for? If a patient is there for a new patient exam, and you ask them, what brought you in today, and they say, I'm just looking to become established. I want to make sure everything's doing okay. If I'm doing an iTero scan and that patient, has malocclusion and I'm concerned that it's wearing down their bite, I'm going to talk to them about that. I'm not going to say, okay, what are your goals cosmetically for your smile? I'm going to say, okay, well, this is what I'm seeing, with your occlusion. Do you see how your lower front teeth are getting shorter and flat? Like, have you noticed that over the years? This is why I'm concerned. You're in your 20s. Think about what's going to happen over the next 3 decades if we don't do anything. Take that same patient. Let's say that they're there for an Invisalign consultation. My approach is going to be totally different. I'm not going to start and say, okay, let's look at your bite. Your teeth are misaligned. They're wearing down. We need to do something about that. I'm going to start with exactly what Chris said earlier. What are your goals for your smile? What would you like to change? In an ideal world, what would you like to change about your smile? And then after we talk about how we can change all those things, then I'm going to talk about what's going on with the malocclusion and say like, hey, so here's the good news. Not only can I fix the cosmetics of your smile, but we can also prevent this problem from getting worse. Versus that new patient, I'm going to start with, they're more concerned about, is everything okay? So we're going to start with the problem and how we can fix it. And then we're going to end with, and the gravy on top is we can give you an even better looking smile as well. So I think you guys, when you're approaching an exam, you need to think about what is the reason for that patient's visit. A whole nother example, let's say that they're there for an emergency exam and they're there because they're in pain. If I see a patient that's in pain, they've got an abscessed tooth, I'm not going to try to put them through a whole, new patient appointment at that point in time. I'm not going to do, Invisalign consultation and talk about, hey, I know you're in pain, but like, we really need to think about Invisalign too. I'm going to focus on that tooth that has the abscess. I'm going to say, you know what? This is what we need to start with. Let's put that fire out. And once we get you out of pain, then let's bring you back and let's make sure that there's nothing else that's heading that direction so you don't have this problem all over again. So I think it's really important that you ask questions, but you also think about what type of appointment that they're there for and like why they're there in the first place.
Yeah, I totally agree. And starting with their first goal, their first objective is critically important. One thing that we will say, either I'll say it or my team members will say it, is something like, if there's anything else that I notice, or if I notice anything else, would you like to know about that? And it's all about getting permission.
Yep.
And I don't see that enough in most dental practices. And again, it's just because that nobody's ever been trained to do that. Just like you said, Matt, there's not very much formal training in this topic. And I believe that every practice, if they were trained, could probably double their numbers because of the lack of training and the lack of understanding in this process. So I think everything we've talked about so far is just so on point that learning about what your patients want and what they're interested in and what's important to them and focusing on that as your first priority, and then maybe blending in other things that they may not have thought about yet, and getting their permission to do so. That to me is the formula.
I have a question for you, Chris. So I was teaching a DSO in Oklahoma 3 years ago. They're probably on 50 practices. And I was in one of their practices that was a really badly performing practice. We had a patient come in. I asked him, what are your goals, your dental needs? He came forward and said, my daughter's getting married in May. My family accuses me of being grumpy in grumpy in photos. I want to smile at my daughter's wedding. And then as I handed off to every staff member, I had made sure that that piece of human information made it to every staff member, that every person we referenced it when they went in the room said, hey, we're excited that you chose us to give you back your smile. We're honored for your daughter's wedding or whatever it was, that everyone would re-reference it and they would um, feel like what's important to them is what's important to everyone else around them at that moment. And I thought made it really good. In your training, I believe that stuff should be recorded in the comms log or somewhere in the PMS. There's always clinical notes, but I'll do consult reviews. We do consult reviews. I'll do a consult review of the doc, and he'll say, "Hey, can I see the X-ray? I don't remember this patient." I'm like, "No, you're not allowed to see the X-ray. There's no human information you have here. You don't remember anything about this person other than by reading their X-ray. That's an indicator of being clinically focused, right? So for you in your training, what is your guidance on handing off that information and where it should be placed and how it should be deployed and how it should be shared to everyone important? Because the clinical information always gets shared, but the human information kind of falls by the wayside, and we try to bring that forward. What is your guidance on that?
Yeah, well, one of the things that we do is we do take notes, and that's something that requires a little bit of balance. I have my team members ask the patient, is it okay if I take a few notes while we talk? Because I want to make sure I transfer everything to Dr. Bowman. And then from those notes, they'll hand off the information to me. They'll also make notes when we're with the patient. So if I'm discussing with the patient, they'll make additional notes. And, that's a handwritten process that can be a little cumbersome, but we make sure that those notes get into the patient's record so that we can reference them later. One new thing that we're just starting to do now is we're starting to use an AI recorder, and using an AI recorder to record the consults I'm just tapping into this, but it's becoming a game changer because
Really?
Yeah. So there's an AI recorder, if you don't mind mentioning the name.
No, go for it.
Yeah, it's called Plaud Note,
Plaud
PLAUD Note. Yeah, it's a relatively new product. I think I got it off Kickstarter or Indiegogo or one of those websites. And what it does is it records digitally the conversation, and then you can ask it to do one of 8 different things or all 8 things. It'll give you a summary, an outline, a transcript. It's unbelievable. And you can use that information later, of course, you could literally copy paste into the patient's notes. So that's a brand new thing that we're doing now. And it'll also allow us to go back and analyze the conversation. And there's no reason why you couldn't use the same thing on a new patient phone call, for example.
So, how much is that? I'm just curious.
Oh, it's like $150 or a couple $100. It's not that expensive at all. You could literally buy one for each treatment room and have them in there. Because, one pet peeve of mine is when a doctor, and I've done this before, when you buy one thing that you really like, and next thing you know, you got the team members looking for it and fighting for it and going up and down the halls. And I just get one for each room. And now we've got one, and you don't have to worry about where it is anymore. But that's a brand new thing that we're starting to implement, and we're just scratching the surface. But I think it's going to be really, really amazing for us.
No, that's awesome, Chris. I'm going to look into that too. So for my implant focused offices, we have a specific intake form that new patients have to fill out their consultations, and it's asking questions like, what negative impacts have your teeth had on you? What have they held you back from? What upcoming timelines do you have in your life of important events? Do you have a wedding? Do you have a vacation? Do you have a reunion, something like that coming up? What are you looking forward to most, once you get your new teeth? So there's like important questions like that. And then when the doctor comes in to do the consultation, now they've got something to go off of. When the treatment coordinator comes in to present the treatment, they're going to go off that same sheet. That sheet goes into their chart, and it also goes into their chart notes. So if they don't schedule their surgery at their consultation, when the treatment coordinator follows up with them, they can say, hey, I know you've got that vacation coming up here in a couple months. If we can get you in for your surgery in the next few weeks, we can get you your new teeth before your vacation. So it's like that information is critical, because once again, it's like we need to know why is the patient interested in this treatment? what is most important to them? What does their timeline look like? And it's not just important for that initial visit. It's important for the follow-ups as well, because not everyone's going to schedule a $20,000, $30,000 surgery at their consultation. Sometimes they need time to think about it. And it makes it much more impactful if we can remember those small details when we follow up with the patient.
That's great. And we've got similar questions on our new patient intake forms as well. And we do have some things like with their smile makeover. Is there something coming up that you'd like to have this finished by? And another important question that we ask in a new patient interview, and this is more of a verbal, need to need conversation. Anytime a patient brings something up that they may be unhappy about. And one of the things we do, just to interject, is we ask patients on a scale of 1 to 10, how healthy would you like to be on a scale of 1 to 10, which sounds like a ridiculous question, but I want patients to articulate the answer. And then we'll ask them, how healthy do you think you are right now? Where would you rate your health on a scale of 1 to 10? And some patients may say a 5 or a 6. And then my team would ask them, what do you think's keeping it from being a 9 or a 10? And a lot of times they'll say that.
Awesome.
And we ask them the same thing about their smile. How would you like your smile to be? Now, some patients, it's not that big a deal. Some may say it's not important. A lot of patients may say, I want my smile to be a 9 or a 10. Where do you think it is now? Well, it's a 4. Well, what do you think's keeping it from being a 9 or a 10? They'll usually tell you most of what it is. And then we ask a very important question, which speaks to the things you just mentioned. How has that affected you? When we ask that question, how has it affected you? If a patient brings up a negative outcome, or, I had a broken tooth, or if they bring up an emergency situation, how did that affect you? And what you just spoke about and what I'm speaking about, it taps into that emotional pain and that emotional feeling that we want to pull them out of. And I believe that you have to let them go there because this is a lot more than just fixing teeth. It's about changing the way people feel. And when we can tap into how they really feel and ask those questions, those probing questions, we have a lot better chance to connect with them at a higher level and then really help them get what they want. So I love the fact that you include those really specific questions. And we have some of those as well. And also that how has that affected you? That's a question that I've found that really gets patients to tap into their emotions. I mean, sometimes we're grabbing Kleenex,
Oh yeah, I've been there.
digging in. Yeah. And that's an okay thing.
That's awesome, Chris. I want to kind of shift gears a little bit and get into discussion about co-diagnosis, because I do feel like that is really, really impactful for offices. If you've got everybody rowing in the same direction, you're going to get there a lot faster. So what does co-diagnosis look like in your office? How do you coach other offices on co-diagnosis? What are some of the important factors there?
Yeah, that's a great question. And one of the things that I believe is really important is that the earlier in the conversation or the earlier in the appointment, these things are brought up, the better. I use an analogy with cooking. And if you'll indulge me for a minute, if you think about cooking and specifically boiling water, most cooking instructions that involve boiling water would say, bring the water to a boil and then simmer. In a lot of dental practices, they do it the opposite way with a patient. A hygiene visit or a new patient visit, they'll see a team member. There may not be a lot of discussion about problems or conditions. They'll do the hygiene and they'll talk about, personal stuff. And that's the simmer. Yep. And then at the very end, the doctor comes in and boils the patient. The doctor comes in and finds everything all at once. And it's almost like a sneak attack to the patient, because the longer that visit goes on without any discussion of problems or conditions, the more likely the patient's going to assume everything's okay, especially if the patient's asymptomatic. And then all of a sudden, here comes the doctor, the money grubber, and it starts to find all these problems. And the patient looks at the hygienist, and what the patient's really saying to the hygienist without saying it is, why didn't you tell me about all this stuff? And the hygienist just obediently nods her head. And then the patient might say something like, well, let me think about it, or let me get a second opinion, or whatever. If you flip that, and this is why it's so important for team members to be involved in this. What I recommend and what I teach is for team members to literally interrupt themselves before they begin the clinical parts of the visit And during the data gathering process, during the charting, the photos, the X-rays, I teach them to take a quick look inside the mouth, get an idea for what's going on, and after the new patient interview that we just talked about, literally interrupt the process and say, you know what, before I go any further, I need to show you some things I'm concerned about.
Great.
And the patient goes, well, what do you need to show me? Or there's some teeth here that are at risk. Now, by that time, they've already taken photographs. Now, what I mean is photographs of quadrants, arches, and smiles, or if you can get really high resolution photographs with like the new iTero is probably the best.
We use the iTero scanner for that. Yeah.
Oh, the iTero is awesome.
Yeah.
It's like miniaturizing somebody and putting them in their mouth. It's so impactful.
Yeah, it's great. And what's really important though is that we take pictures of groups of teeth, quadrants, arches, and smiles, because I want my patients thinking in terms of groups of teeth as opposed to a bunch of individual pictures of individual teeth with an intraoral camera. I mean, sometimes I look at like 9 pictures on a screen and I don't even know where those teeth are. I'm having trouble. So if you get the picture of an arch or a quadrant or a smile on the screen, and the team member can say, you know, these are some things I'm concerned about. You know, if it's a hygienist, before I start your cleaning, I need to show you some things I'm concerned about. Because, you know, earlier you told me you want your teeth to be really healthy. These things aren't going in that direction. Now, if a team member says that before she starts the cleaning, for example, then they're going to get the patient's attention and sit the patient up, show them the photographs, go through. And as far as the co-diagnosis part, one of the things that I'll have team members ask the patient is, you know, do you see anything here that looks like it's out of place? And see if the patient, sometimes the patient doesn't say a whole lot. And that's okay, because then the team member can say, would it be okay if I share with you what I see? So again, gaining permission. We're not just talking at them and saying, this is what you need. We're getting permission to share with them what we see. And then she can go through, or he can go through with a patient and go through each thing and, you know, see these blue shadows under your fillings in plain English, not clinical terms, and discuss those issues. Another thing that we do that's very unique is I'll have team members show patients photographs of other patients' teeth right after removing like an old filling or an old crown, but before removing all the decay, so that they can see what someone else's teeth look like that have fillings and crowns that look like theirs, but they can see all the stuff that's going on underneath it. So it's kind of gross, but it's important for them to understand what's going on. And, you know, those are some of the things that we do to involve the patient. And I call it the problem presentation system. And when we present problems and conditions in a certain way to engage the patient, then they become more motivated to have those corrected, if that makes sense.
That's a lot of really great points there, Chris, that I want to touch on. I want to start with how important imagery is, though. So, you know, guys, if you think about it, if let's say you take your car in for an oil change, and let's say you're like me and you like to drive cars, but you don't know a whole lot about how they work. And, you know, the technician comes back and says, oh, this is going bad. This is going bad, you know, blah, blah, blah. I just have to believe him. I either believe him or I don't believe him. I either fix it or I don't fix it. But typically, most of these places, they're not showing you pictures of things. They're not explaining what you're seeing in those pictures. They're not showing you a picture of what something should look like versus what something shouldn't look like. If I went in there and they showed me all that, you better believe I'm a lot more likely to say, yes, let's fix it today versus, maybe I'll fix it next time. Our patients are the same way, guys. Like they're just sitting, they don't know a whole lot about how things work with their teeth. Most of them, at least, they're just choosing to trust us, not trust us. If the most powerful things I have in my office are some of the cheapest things I've invested in, like my $200 50-inch TV that's sitting right in front of the patient that we can show them their x-rays and their scans and IO pictures on, like that couple $100 mouthwash intraoral camera that we use. Now, the iTero is a different story, but either way, you know, it doesn't cost a lot of money to buy an inexpensive intraoral camera and a TV. And if you don't have those things in your practice right now, like you should go out today and buy them, because it's going to totally up your treatment plan game if you can actually show patients. And again, on a 50-inch TV right in front of their face versus having them turn around and look at the small computer screen, that makes a huge difference too. So you want to be able to blow these things up. So imagery is huge. We have a role in my offices. When the doctor walks in the room, something better be on that TV that's diagnostic, whether it's a, IO picture, scan, x-ray, something like that. I always tell the team, whatever you feel like is the biggest issue and is the most diagnostic thing that the patient can see, have that up on the TV. So that way they're looking at it whenever we walk in the room. And that's typically kind of how that handoff starts is, hey, doc, we've been talking about a few different things, but my biggest concern that I really want you to take a close look at is this tooth because of this problem. You can see it up on the TV there. And that way I walk in and say, oh yes, you're absolutely right. Thank you so much, Kelly. We definitely want to take a close look at that. Guys, the worst thing, the opposite side of that, the worst thing is when I walk into a room and the hygienist says, oh, everything looks pretty good, doc. They're in good shape. And then you take a look and realize that they need a handful of fillings and crowns because it's really tough to overcome that. Once they've had that, visit with the hygienist where they've got lulled in this false sense of security that everything is great. And then to make matters even worse, the hygienist says things look great. Now you're contradicting the hygienist and now you're trying to convince the patient that there really are problems and the patient doesn't know who to believe. So now you and your hygienist are on totally different teams. So I'm really big on empowering our teams. I always tell our hygienists, you are mid-level healthcare providers. For those that don't know, hygienists are the second most commonly seen healthcare provider in the world, right behind pharmacists at number one. So, patients actually go and spend time and see their hygienist more than anybody else. We need to empower our hygienists to really think critically. I always tell them jokingly, you're not just probing robots. You are healthcare practitioners. We want them involved in the whole body health. We want them talking to patients. If a patient has, gum disease, we're not just talking about, a little bit of inflammation or bone loss. We're talking about dangerous bacteria that lead to increased risks of things like heart attack, stroke, diabetes, and Alzheimer's. If they're seeing fractured teeth, they're showing the patient the fracture. And, again, they don't have to truly diagnose it. They can say, do you see this? Do you see this thing that's lying on this tooth? To me, this looks like a crack. When teeth start to crack, it could become a problem like a windshield. If you think about a little nick in a windshield and how it can start to splinter across the whole windshield, that same thing can happen with your tooth. I'm concerned about this. I know Dr. Vallo is going to be concerned about this. We're going to make sure that he takes a close look at this for you. And then the ultimate win is when you walk in the room and before the hygienist can even say anything, that patient says, doc, I think one of my teeth is cracked. It needs a crown. How soon can we do that? Do we have time to do it today? So that is the ultimate win. All of this said, guys, going back to my point about the hygienist saying everything looks great, doc, and then you realizing there's a bunch of problems going on, you have to calibrate with your team too. So, you have to spend time sitting down with your team, going through x-rays, going through IO pictures, and have them actually make co-diagnosis lists. Put up a series of x-rays on the TV and say, hey, I want you to write down everything you see that you might be concerned about and have everyone write down separately and then go over it together. Doing that repetitively, that's the only way that you're going to calibrate and you're all going to get on the same page about things that you're going to see and that you're going to want to talk about so that you don't have those issues. And then my final point I'm going to make, and then I'm going to let Chris get back into things. But when you need to make sure that you're not going to throw your hygienist under the bus too. So if you do this and you empower your hygiene team and you come in and the hygienist is all excited and they say, hey, doc, I see this crack on this tooth. I'm very concerned about it. I want you to take a close look. And you get in there and you say, no, that's not a crack. That's just some normal anatomy. Now this hygienist is completely deflated. And guess what? If she thinks she sees a crack next time, she's not going to say anything about it. So just some important points to consider, when it comes to co-diagnosis, guys.
Man, I'm in total agreement with everything you just said. And it brought up some important points and some things that I really cover very emphatically in my training. One of the things I took a couple of notes here, your point about hygienists and even assistants, really anyone in the practice being providers. is so important. And, a lot of times I hear assistants or even hygienists or even associate dentists say, I'm just an associate, or I'm just a hygienist, or I'm just an assistant. One of the things I do in my course, and I might have 6, 8, 10 dental practices and their teams all in the same room, could have over 100 people in the room. I have everyone stand up and I start to have them sit down by the number of years they've been in dentistry. So when I get down to less than 2 years in dentistry, we've got a few people standing up, and then I'll go down to 1 year and maybe 6 months and sometimes 3 months, and I have 1 or 2 people left standing. And at the very end, again, you got 1 or 2 people left standing, and I look at those 2 people and I say, you're a dental expert because you know a little bit more than your patients do. And the point is that we should all leverage the legal capabilities of every one of our team members and to the fullest extent. Now, that brings up another important point that hygienists especially usually have an issue with, and it's because it's been drummed into their heads in hygiene school. We all know that they're smart enough and that they're knowledgeable enough, dental assistants are as well, to know when there's a cavity, for example, or to know when there's a cracked tooth. So you hear it all the time. A hygienist would say something like, I can't diagnose. And I would say, you're right. You can't legally, officially diagnose, but here's what you can do. You sure can recognize when something doesn't look right. And you can relate that to your patients. Assistants can do the same thing. Even front office people can usually recognize if something doesn't look right, especially if they go back to the calibration point that you made earlier. That's another point of emphasis in my training, is exactly what you just said, is spending time going through photos, going through x-rays, and just like you said earlier, Matt, role playing that out and describing it to a patient in plain English, not dentalese. Dentalese is that foreign language that we learn in dental school that we shouldn't speak to anyone else. I always say, if you want to use dental terms, go to a conference and speak dental terms to another dentist. It's fine.
That's strong advice. That's good.
Yeah. So the other thing is some of the common questions that we may even ask a patient on the front end of a visit can actually put us in direct conflict with that patient later. For example, are you having any problems? Very common question. I don't believe we should ask that question. Is there anything bothering you? We shouldn't ask that question because most of the time patients are going to say, no, I'm not having any problems. No, nothing's bothering me. And then the next thing we do is we go in and find a bunch of problems.
Yeah, and then you look like the used car salesman style of dentistry then.
Yeah, we're in direct conflict. Yeah. Well, what I would recommend that we ask is there anything that you notice? Are you noticing anything that could be an issue? Have you noticed any changes? Like for a recall patient, have you noticed any changes since I saw you last time? Now, they may not have noticed any changes, but we can find things that they haven't noticed. And that gets them off the hook for being wrong. And, maybe because I was a psychology major, I started thinking about all these things and how can we avoid conflict with patients and show them that we're on their side? Because I don't want to create a situation, and again, like you said, Andrew, where the hygienist is wrong or the dentist is wrong. I don't want the patient looking at two people in the same practice going, well, which one of them is right? If I do have that situation where a hygienist recognizes something and maybe I don't feel like it's a cavity at this point, I'll say, you know what, Emily, I'm so glad you noticed that. Man, she's got an eagle eye. Isn't it great that you have a hygienist that notices these things and that has such a good eye? Here's the good news. I think that this particular situation, I think it's okay for now, but let's monitor that. Let's put it on the radar. So now she's not wrong. She recognized something that didn't look right. I kind of said, well, maybe not yet, but I didn't make her wrong. And to me, that's really important because I want to empower my team members to have the confidence to do this over and over and over again. And by the way, we've had that conversation before this even happens, that, hey, if you recognize something and I may not feel like it needs treatment right now, I'm going to say it in a way that empowers you and that makes you look really good in front of the patient. So that takes some finesse, but it really makes a big difference and it gives the patient confidence in your team.
I love that qualifying word, yet. So, you had mentioned before, you don't think we should ask patients, is anything bothering you? Is anything hurting? And I agree. Like in general, we should not come into the exam and say, is anything bothering? I often say, do you have any questions about any of your teeth? I love have you noticed anything that's changed? Like that's great too. But like when I see a problem or when a hygienist sees a problem, what we like to do is we like to say, are you having any pain yet? Is that hurting yet? Because then there's that qualifying question that says, it's going to hurt at some point. Has it gotten there yet? Okay, great. So then I like to say, great. I'm so glad it's not to the point where it's hurting yet. It could come any day now. Let's try to take care of that before it starts to hurt you. I love when we can take care of problems before they start to hurt because it's easier to get you numb. The post-op is easier. You don't have to sit through a sleepless night. And I'll often also tell patients, and I kind of do it in a joking way, but kind of serious as well. Just keep in mind that these problems tend to flare up and hurt for whatever reason at like 3 a.m. on a Saturday night. Yeah. And Dr. Vallow does not come into the office at 3 a.m. on Saturday nights because his wife would kill him because he's got a 16-month-old baby. So, you say that, they kind of chuckle a little bit, but at the same time, it reinforces at some point in time, this issue is going to lead to pain, discomfort. We don't know when it's going to be. It could be at a very inopportune time. The best thing to do is to just take care of it as soon as possible before it gets to that point so you don't end up in the emergency room in the middle of the night. So.
No, that's really good. And, one of the things that came to mind when you were talking about that was the idea of trying to, what I call pre-eliminate objections that patients may commonly have. So, I mean, how many times have we seen discussions where we bring something up and we recommend treatment for a patient and they'll look at you and say, well, it doesn't hurt, almost insinuating that they really shouldn't do anything about it until it hurts. One of the things that I might mention to a patient, even my team members will mention it to a patient, is something like, you're probably not even feeling anything right now. You're probably not even having any symptoms. And they're going to say one of two things. They're either going to say, yeah, you're right. Or they're going to say, well, it has been a little sensitive. And which is actually really good if they say that. But even if they say, no, you're right, it hasn't bothered me at all, it shows that we understand that you could have problems with no pain. And that's another thing. One of the things that I say a lot in my training is that patients aren't going to just know. They're not going to just know all the things that we know. And they don't think like we think. So they're not going to just know that they could have problems and not have pain. But if you think about a lot of medical diseases, for example, you could have a pretty serious medical disease and have no pain, but then the doctor runs
high blood
routine
pressure
tests and they find out there's something serious. And same thing in dentistry. But for some reason, I think it's because dentistry used to be a reactive profession. It used to be, I'll call you when something hurts.
It still is in some countries.
Yeah, you're right. And I think patients
I think the patient culture is reactive. I think that's the problem.
Yes.
Patients,
I agree.
Patients only seek you when they have a problem that's changing their quality of life. Yeah, it's hard to. That's really what drives that.
Yeah, that's a great point. And to your point earlier, Andrew, yeah, let's tackle this before it becomes noticeable to you. Let's tackle this before the tooth breaks, because when it breaks, I may not be able to fix it when it breaks, because I can't control how it breaks, but I can control it before it breaks. So developing a little bit of that tension and that cognitive dissonance, in the patient's mind, is really important in motivating them towards accepting your care. And that brings up another important point. Most people perceive dental work to be, uncomfortable, inconvenient, and expensive, obviously. Well, and at the same time, intuitively, we may not want our patients to feel uncomfortable when they're in our practice, because it's psychologically uncomfortable for us to make them feel uncomfortable. Well, in my opinion, the only way that a patient is going to move forward with treatment recommendations if they feel more uncomfortable with the idea about how things are in their mouth than the perceived discomfort they have with getting the dental work done in the first place. So they have to really become uncomfortable with how things are in the direction that they're heading in order to want to do something about it. And which brings up another important point about diminishing terms. We really have to avoid things like, oh, it's a little crack over there, or, you kind of have a cavity. I'm not sure how somebody could kind of have a cavity, but
it's like kind of having a flat tire. You either have one or you don't. It really is.
Yeah, we naturally use these terms to kind of lessen the blow, but I try to take those things away. No, there's a crack there. There's a fracture line in this tooth, and there's a cavity under your filling. And, by definition, a cavity under a filling is bigger than the filling. So,
Yep.
It's deeper than the filling. And we just have to make sure patients understand that. And the only way is if we can relate that to them.
Yeah, I always say you don't want to sugarcoat the problem, but you do want to sugarcoat the diagnosis, or the treatment. So make the treatment sound easy, but make the problem, I don't sugarcoat it. I mean, tell them what it is. This is something that I used to struggle with as a newer dentist, because I think you come out of school and you don't want to upset people. You don't want to give bad news. I mean, Mark Costas always says, the level of your success is measured by the number of difficult conversations that you're willing to have. Having a blunt conversation with a patient about a problem they're having is a difficult conversation. I mean, it's a muscle that you can build just like anything else. And the more you do it, the more comfortable you get and the better you get at it. And I agree with you 100% there, Chris. And actually, I believe I heard you speak about this, and I stole some of those pearls from you from another podcast, maybe. But I have a slide in my associate onboarding PowerPoint. One of the slides that we go through talks about this very thing. You don't have a little bit of inflammation, you have a gum infection. You don't have a small crack, you have a crack. And then my analogy is, on the slide to my associates, to try to make them see this for what it is. Your plumber wouldn't come to your house and say, you've got a small leak in one of your pipes, but your house probably isn't going to flood. You could probably wait to fix that leak. No. You're going to want to fix that leak immediately. So it's the same thing with dentistry. We can't be downplaying the problems. It's not up to us to make the decision for the patient whether or not they should fix the problem yet or not. It's not up to us to decide for our patients if they should be proactive or not. Guys, we're not doing our patients any favors by downplaying these issues, by trying to watch these issues. Because here's the thing, like in your mind, you might think, you know what, patient has bigger fish to fry. This cavity is small enough. It's probably not going to get a lot worse in the next 6 months. But how do you know that patient's going to be back in the next 6 months? Even if you have that 90% reappointment rate, they might miss that appointment. Something might come up. They might not reschedule right away. They might disappear for the next 18 months. And now all of a sudden they're back. And that small cavity that you either downplayed or didn't even tell them about is now a big problem. And now maybe they need a root canal and a crown. And the patient's mad. And they're saying, Doc, how did this get so big? Why didn't you tell me about this before? And you're sitting there thinking you were the hero. You're the one who's helping the patient avoid treatment, when in reality, you're making the problem a lot worse for them. So, at the end of the day, it's always a patient's decision if they want to do treatment, but it is our responsibility to point things out to patients and just be blunt about it. Don't sugarcoat it. I mean, you still have to have a good bedside manner, but at the same time, like you just got to get to the point with what the problem is. And then again, where you swoop in with the sugarcoating is, but don't worry, we can fix it. I have an easy solution for you. It's only going to take 90 minutes. I mean, guys, if a patient's never had a crown before, they might think that's an all-day appointment. They might think that they have to be put out and they've got to have a driver for that appointment. Don't worry about it. We can fix it. All I've got to do is put a white crown over the tooth. It's like a new roof for a house. It's going to protect it. You get to keep your tooth. That appointment only takes about 90 minutes. I'm going to have you nice and numb and comfortable. You can drive home right after, no problem. You're not going to miss any work. So you have to sugarcoat the treatment and let the patient know how long it's going to take, how easy it's going to be, what the post-op recovery is going to be like. Because if you don't, they're going to build it up in their minds and they're going to think it's a lot worse than it actually is.
Yeah, absolutely. I made a couple of notes when you were speaking, and one of the most important points, and I call it a foundational principle in my practice as well as my training, it's literally a motto in my practice, and it's give everyone the opportunity to say yes or no to your best care.
Love it.
And when you give everyone the opportunity to say yes or no to your best care, you allow the patient to decide. Now I also said you got to give them all the available information as well. And you also have to learn what's important to them and all the stuff we've already talked about. But what that does is it takes away the responsibility from the dentist to say yes or no. And it takes away the fear of them saying yes or no. It's their choice. I don't recommend that we necessarily watch things, quote unquote, watch things that we recognize to be a problem. I would say let the patient watch it. Let them know what you see, recommend a solution, and again, give them the opportunity to say yes or no. Let them watch it. If they want to watch it, they can watch it. I'm not going to watch it. I'm not going to watch it get worse. Another thing I like to share with patients is I love telling patients this because we've all seen relatively small cavities that turned into deeper cavities, and I'll tell a patient this all the time. I'll say, I don't want to tell you it was deeper than I thought. I don't want to say that to a patient. And I'll tell a patient directly, I don't want to tell you that. So the sooner we get at this, the better. Now, I also do give them what I call relative urgency. If it's a brand new incipient cavity in a premolar, I'll say, yeah, this looks like it's really early. It's just getting started. It's the best time to fix it. And you've got a good time window here. You don't have to stop the world from spinning and come in tomorrow and do this. But I'd say if you get this done in a reasonable period of time, it's still probably going to be really easy, But one thing I don't want to say is that it was deeper than I thought, by letting it wait too long. So just a bunch of different ways to mention things to patients to make it real for them.
Chris, this has been such a great episode. But
really great episode.
I know awesome. We need to wrap things up here.
Yeah.
So I honestly, I could talk about this stuff with you for hours, but
I could too. Yeah, sure.
For the listeners, if they are, interested in learning more from you about treatment presentation and how to get patients to yes, what are the easiest ways that they can find you?
Yeah, I'm going to give you two solutions. One might surprise you. I'm going to give you my mobile phone number, and I invite anyone listening, if you have a question or if you want to communicate with me directly, just shoot me a text, and I'm happy to receive that. I get several texts a day, and it's not overwhelming. My mobile phone number is 704-968-2002, 704-968-2002. And there's a really simple domain name that I'll give out, and it's called gettingpatientstoyes.com, gettingpatientstoyes.com. It's a very simple opt-in page where you can include your information, and that'll allow me to reach back out to you and share information with you about upcoming trainings. My Getting Yes Masterclass is a 2-day program, and I can either, in some cases, I can come to you if you want me to come to your practice, or I also have the same training in certain cities around the country, and I'm going to be launching new locations and dates very soon. So if anyone wants to know about that, just go to that website or text me, and I can get you all the information you need.
Awesome. And guys, just again, keep in mind, we don't have any sponsors.
Well, hey, it was great, Chris. This is good.
I was going to say, Chris is not a sponsor. Chris is just somebody who, honestly, while I don't know you that well, Chris, I think we met at a couple events over the years. Yep. He's been a mentor to me, like many of the other great dentists out there, because I learned most of what I know from the dental podcast. So I'd heard a lot of the stuff Chris had to say before. It was great to actually talk with you about a lot of these ideas and principles. Thank you for everything that you do, sharing in the world of dentistry, because I know you've had an impact on me and my practices as well. So thanks again for coming on, Chris. Look forward to speaking with you again soon. And thanks everyone for listening. I hope everyone has a great day.
Hey guys, please appreciate that. Hey, listeners, please make sure you like and subscribe, hit follow, and leave a positive review. Like Andrew said earlier, we don't have any sponsors. We do this for the benefit of the community. So please share, like, subscribe, and follow, and that'd be really appreciated. Thank you guys so much for joining us. Have a great day.